Okay, I'm gonna get started. Good morning, everybody. Thank you for joining this morning. We are lucky to have Dr. Natasha Martin with us today. She's an infectious disease economic modeler and a professor in the Division of Infectious Diseases and Global Public Health at UCSD. She co-directs the NIDA-funded T32 program in substance use and HIV, as well as the UC Global Health Fellowship. And she is also a co-director of the Biostatistics and Modeling Core of the San Diego Center for AIDS Research. You all know Natasha pretty well, but for those who might be new to the high rounds, her primary research focuses on modeling hepatitis C virus and HIV transmission and prevention among key populations, such as people who inject drugs. And her modeling work has informed several WHO guidelines, including when to start ART in people living with HIV, and the WHO Global Health Sector Strategy on Viral Hepatitis. And she will be talking to us today about modeling the impact and cost effectiveness of Proyecto ESCUDO and on HIV and overdose among people who inject drugs in Tijuana in Mexico. And we're very much looking forward to your talk, Natasha. I'm gonna let you take it away.
Thanks so much, Inique, and thanks everybody for having me speak today. So I'm really honored to be presenting this work. It's work that has been building, and subsequent people have been expanding on this work over a number of years, actually since I arrived at UCSD in 2015. And it really leverages decades of work led by Stephanie Strafty in Tijuana and the border region, an intervention study on police education that was co-led by Steph and Leo Boletsky, and highlights modeling work done by our faculty members here, Anique Borquez and Javier Cepeda, who was a faculty member here before he got hired away to Johns Hopkins University. And finally, I really just wanted to elevate Daniela Abramovitz and Carlos Rivera Saldon, who have also contributed to these pieces. So really a group effort in terms of looking at a lot of interesting things over time, which I hope you'll find interesting. Before I get started, I just wanted to do a little plug again for this GloCal Health Fellowship, which I co-lead on the UCSD site PI. It is a global health fellowship. It supports 1 year of fellows who are interested in doing global health research abroad. It funds both US doctoral students, so PhD students, et cetera, as well as professional students such as MDs. It also funds US postdoctoral fellows and postdoctoral fellows from our affiliated low to middle income countries. We have about 17 sites, so that's a lot of countries to choose from. And the interest area of this fellowship are very broad, as you can see here: nutrition, environment, medicine, public health, et cetera. So if you have anyone who's interested in spending a year abroad working on global health, please let me know. Particularly, we are really trying to get interested US postdoctoral fellows, and they don't even need to already be here at UCSD. So if somebody is interested in coming to work with you, this is one great vehicle. They can apply for the fellowship, and if they get the fellowship, they can come to UCSD as a postdoc. So consider that, and let me know if you have any questions. Great. So these are my disclosures. All right, so today's talk, I'll be talking a little bit about the 3 different types of models that I will be describing today. A lot of modeling going on. I am a modeler. And then I'll talk about policing and HIV risk among people who inject drugs in Tijuana. I'll talk about drug law reform in Mexico, what happened. And then the main bulk of my talk will be talking about this police education program, Proyecto ESCUDO, and our evaluation of that. So I know this can get confusing, so I just wanted to highlight that in this talk, I'm actually going to be talking about 3 different types of modeling work that we've done to inform our analyses over time. The first is some statistical modeling, epidemic modeling, and economic modeling. So briefly, what are these? So everybody here will be familiar with statistical models. Just to recap, statistical models describe associations between variables. So that's, probably the most commonly used type of modeling that's used in sort of epi. But my main focus of area of interest is epidemic modeling. And this is a different type of modeling. We develop transmission models. These are mechanistic models that simulate transmission, infectious disease transmission in a population. And they provide a mechanistic representation for how the epidemic was established in the past and can project the epidemic forward into the future under various conditions. And what this allows us to do is assess long-term or downstream population health outcomes of interventions. The last piece of modeling that I'll be describing today is economic modeling. And economic models assess both the costs and the health benefits of an intervention strategy. They can incorporate epidemic models if they want to incorporate transmission prevention benefits or not. They can just look at the impact of a treatment or intervention on an individual's own long-term health outcomes. And these are really useful because even if an intervention is effective, and for example, an epidemic model indicates that an intervention might reduce incidence in the future, governments also want to know if it's good value for money. Is it cost effective? And so that's where the economic models really provide that kind of information to policymakers. So today I'll be talking about a structural intervention to reduce HIV and overdose. And here we're looking at the socio-ecological framework of HIV transmission dynamics, going from sort of individual level factors that can drive risk all the way up to structural factors. And what I'll be focusing on here is in the bottom left, we're thinking about how legal structures such as laws, law enforcement and incarceration patterns can fuel HIV transmission risk. And how interventions that intervene on these, such as the police education program that I'll be discussing, could provide positive benefits in terms of health outcomes among people who inject drugs. And so the study setting that we're looking at today is in Tijuana, Mexico. As we all know, Tijuana, Mexico is a major border city, and it's a nexus for trafficking illicit drugs into the United States from Mexico. There's a high infectious disease burden and low prevention access among the approximately 10,000 people who inject drugs in Tijuana, with an approximate 4% HIV prevalence among people who inject drugs and minimal access to treatment and prevention interventions. So across our the Stephanie Strathdy and others' studies over many years, less than 5% of people who inject drugs are consistently report being on opioid agonist therapy. Less than 10% of people who inject drugs with HIV are on antiretroviral treatment, and there's very limited needle and syringe programs, particularly after the World Bank reclassified Mexico as a middle of the high income country and withdrew their financial support for syringe service programs. One thing that I will mention is this issue about opioid agonist therapy is particularly and urgently relevant right now. I won't go too much more into this in my talk, but Mexico just recently closed their only manufacturing plant for methadone, and there's a huge shortage of OAT nationally, which is an urgent public health issue. Okay, but today I'll be talking about police practicing and HIV risk. So abusive policing is pervasive in Tijuana, as well as other places in Mexico, which contributes to risk among people who inject drugs. There have been a number of studies, both in Tijuana and also globally, indicating that there's increased receptive syringe sharing among people who inject drugs, which is associated with both incarceration, syringe confiscation by police, and other negative police interactions. And this is also supported by global systematic reviews done by our team, which shows that recent exposure to incarceration is associated with increased HIV and hepatitis C acquisition among people who inject drugs, which persists even long-term after post-release, and is also associated with fatal overdose. And so this picture is increasingly complicated when we're thinking about how to address HIV prevention in Tijuana, because we have substantial overlap of key populations as well as transmission risks which fuel HIV. So studies that have been running since 2003 in Tijuana across a number of investigators here at UCSD have indicated that there is, as you can see here, substantial overlap in key populations. So for example, over half of female sex workers in Tijuana report injection drugs. And of course, there is overlap of both, for example, injecting and sexual risks for HIV, which make allocation of resources and our understanding of how to best intervene on the epidemic difficult in this setting. And so what our team did, leveraging data from 10 NIH-funded studies across a number of years, was to develop an HIV transmission model among key populations in Tijuana. This model was led by Hannah Fraser, Peter Vickerman and his team at University of Bristol, as well as our collaborators here at UCSD. And they built this transmission model and calibrated the model to many years of data, as you can see here on the right-hand side, for HIV prevalence and incidence among these risk groups over time. And what we found from that model was that 94% of infections from 2020 to 2029 are likely due to unprotected sex between men or injection drug use. And among people who inject drugs, a high proportion, 86% of infections are related to injection drug use, but an important sexual risk remains. So helping us understand that we need to address both sexual and injection risks among this population. So how can we do that? Well, one interesting policy development that happened was the set of drug policy reforms that was instituted in 2009 in Mexico. These reforms decriminalized possession of small amounts of drugs. They suggested referral to drug treatment on a third apprehension, but they didn't mention or specify exactly what type of drug treatment this should be, and I'll get back to that in a moment. But the laws on drug trafficking remain the same. And our group hypothesized that these reforms might have a positive benefit on reducing HIV and other infections among people who inject drugs in Tijuana. And this is because we see consistent associations between exposure to incarceration and syringe sharing. So we posited that if possession of small amounts of drugs were decriminalized, that people who inject drugs would experience reduced incarceration. And here, this is a nice analysis done by Carlos Rivera Saldon while he was a doctoral student here at UCSD, where he looked longitudinally among people who inject drugs in Tijuana, among those who had never been incarcerated at baseline. And we were able to follow their incarceration patterns over time and track how many times they'd been reincarcerated and whether they were recently released or not. And what you can see here is that individuals who were recently released, which is the first two columns, had an increased risk of receptive syringe sharing compared to those who had never been incarcerated, and that this risk increased with the increasing number of incarcerations. There's sort of a dose response here in terms of repeated incarceration risk. And then at the bottom, what we saw was that in receptive syringe sharing risk persisted even among those who were not recently released, or so who had not been released in the past 6 months. That risk was slightly attenuated, but still persisted over time. And again, this is consistent with data that we've seen in other settings. So what actually happened after the reform? Well, Anique Borges looked at this, and what she saw was that actually there were no changes in incarceration observed among people who inject drugs after the reforms. And unfortunately, there was negligible access to evidence-based opioid agonist therapy before the reforms, and no change afterwards. Unfortunately, also in 2014, the government of Mexico funded non-evidence-based compulsory abstinence programs, which investigators such as Claudia Raful and her team and Anique Borges have shown that these compulsory abstinence programs effectively act as prisons. They're associated with increased syringe sharing risk as well as overdose. So really could be a negative outcome of funding of these programs. We did see minor changes in police harassment after the reforms. Recent syringe confiscation by the police declined. It was about 10% before the reforms and did not occur very much after the reforms. So that was the one positive change that we observed. So why didn't anything change? qualitative work done by Stephanie Strafty and her team showed that there was little knowledge about the reform among the Tijuana police. So in 2015, less than 10% of them correctly identified the heroin possession threshold. So this is many years after these reforms were implemented. They still did not know the threshold by which it was legal to carry possession, and only half of the police recognized syringes to be legal, which they had always been. For those that did know about the reforms, they typically identified mass media as their main source of information, and they reported conflicting local laws and no operational procedures to implement these reforms, even if they did know about them. So they really just either didn't know about them or hadn't been given the tools to enact them. So Anik Borg has led this great analysis that showed effectively the missed opportunity of what these reforms could have achieved. And so she developed a model of HIV transmission among people who inject drugs in Tijuana. And she used that to look at the percent of HIV infections which were prevented among people who inject drugs, could have been prevented from 2018 to 2030 if with these reforms. Now, I mentioned there was small changes in syringe confiscation. So with what the small changes that we saw and the limited reform knowledge among police, her model estimated relatively little impact as of 2017, and if continued, only 5% of HIV infections averted with this small change between 2018 and 2030. Additionally, this government funding of compulsory abstinence programs could cause harm and actually increase new infections, which was concerning. And her work showed that, however, if the reforms were implemented properly and people who inject drugs were had experienced reduced incarceration as well as referral to evidence-based opiate agonist therapy, this could avert 21% of new HIV infections from 2018 to 2030. So, based on the findings of these studies, Leo Beletsky and Stephanie Strafty implemented a NIDA-funded study called Proyecto ESCUDO, or Project SHIELD, which was aimed to align policing with public health in Tijuana. It was an educational intervention. It was bundled within an occupational safety framework. And in 2015 to 2016, it trained virtually the entire police force in Tijuana, which was over 1,800 police officers. They followed a subsample of the police officers prospectively for 2 years to measure their self-reported attitudes as well as behaviors over time related to interactions among people who inject drugs. And then we were able to follow in Stephanie's cohort of people who inject drugs their reported exposures to the police to see whether we could triangulate any changes in behaviors reported by the police with actual experiences reported by people who inject drugs on the ground. So the intervention was developed in partnership with the Tijuana Police Academy. It was a train-the-trainer model. It was culturally adapted by the instructors, and it was a 3-hour course that was divided into 3 modules, which covered basic epidemiology, prevention and treatment of HIV, hepatitis C, and TB. It covered the relevant state and national drug policies and reforms that I mentioned. And it also just covered general elements of harm reduction, drug use, and public health. And so among the police officers that were followed, as I mentioned, we could compare before the reforms and 24 months after the reforms. And what Javier Cepeda found was that among the police officers, they reported a significant change in their behavior in terms of, on the left-hand side here, significantly reduced frequency of making arrests for syringe possession in the past 6 months before compared to 24 months after, as well as significant reductions in frequencies of making arrests for heroin possession in the past 6 months over time. So we saw improvements in knowledge and attitudes, as well as self-reported changes in behavior among the police. But what did we find among people who inject drugs? Well, at this point in my time, a model, I'll emphasize that. Okay, so the first thing we did was we wanted to use statistical modeling to understand, was ESCUDO associated with changes in recent incarceration among people who inject drugs? And then we would feed all that information into our downstream epidemic and economic models. Okay, so this was work that was led by Javier Cepeda and Daniela Abramovitz, and we looked at incarceration among people who inject drugs in Tijuana, and we could see, we looked longitudinally over time. The green here is pre-training or pre-ESCUDO, the yellow is during training, and the blue is post-training. And what they did was a segmented regression analysis. And they first built this multivariable marginal log binomial regression model. The outcome is past 6 months of incarceration. And we had a number of covariates in terms of gender, receptive syringe sharing. We had a government change that happened midway through the intervention, which could have changed some of the exposures. And we looked at other potential covariates as well. And then we use this to inform a segmented regression analysis using the estimates from this binomial regression to compare the risk of past 6 months incarceration pre-ESCUDO to post-ESCUDO. And you can see here what happened pre-ESCUDO as well as post-ESCUDO, really showing a relatively stable incarceration pre-ESCUDO and a marked decline post-ESCUDO. What did this translate to quantitatively? Well, quantitatively from the segmented regression results, we saw no significant trend in recent incarceration pre-ESCUDO. So there really was no change in incarceration prior to no statistical evidence of a change prior to the ESCUDO intervention. But we did see, and we also saw no significant immediate step change or level drop in the risk of incarceration post-ESCUDO. But what we did see was a significant slope change in trend, which we saw in my previous figure, that decline over time post-ESCUDO intervention. And so what we saw was a 21% reduction in risk of incarceration in each 3-month period post-ESCUDO compared to pre-ESCUDO. And that again is sort of shown in this model where really there was no significant evidence of significant trend in incarceration pre to the intervention, no immediate change after the intervention, but a kind of a 21% decline in each 3-month period. Okay, so then we take the findings from those statistical models and we wanted to feed them into epidemic models to estimate how many hepatitis C and HIV infections and fatal overdoses were prevented with ESCUDO and could be prevented in the future among people who inject drugs in Tijuana. And so we used several models for this. First, I'll start with the HIV model. So we adapted a published HIV transmission and overdose model among people who inject drugs, calibrated to HIV prevalence, incidence, and incarceration patterns that had been developed by Anique and was subsequently adapted by Javier Cepeda. We simulated an intervention and a comparator. So the intervention was what we observed, the declines in incarceration among people who inject drugs after ESCUDO for 2 years. That was just the time where we observed impact and we could triangulate that against the self-reported behavior change among police in their follow-up. We also simulated a scenario where that impact extended for 10 years, a sort of sustained impact that we might expect potentially with retraining of the police force. And we compared those to a counterfactual of no changes in incarceration. So assuming that the incarceration trend remains stable over time, as we saw that it was stable before ESCUDO. And the outcomes that we first looked at were HIV incidence and fatal overdoses over 2 and 10 years. And then I'll get to hepatitis C later on in this talk. So what did we find? Well, we found that just over the 2-year period of ESCUDO, the changes in incarceration, which as I mentioned, are associated with increased risk of receptive syringe sharing, could have prevented just under 2% of new infections and 12% of fatal overdoses among people who inject drugs. And that's just among that 2-year period. Now, then we fed that into economic modeling. And the question here is, was ESCUDO good value for money? Was it cost effective? Now, I wanted to get back a little bit about cost effectiveness analysis. So again, cost effectiveness analysis is a tool to help us understand whether an intervention is good value for money. And it's always comparative. So you're always comparing two courses of action. Usually, for example, we would be saying, is an intervention good value for money compared to status quo, compared to what we're doing right now, or comparing, intervention A to intervention strategy B. And so because this type of analysis is at its heart comparative, the traditional output is what's called an incremental cost effectiveness ratio, or ICER. And it compares a strategy, let's say B, to a strategy, let's call it A. And it's actually a relatively easy thing to calculate. It's the ratio of the incremental cost of a strategy, for here, example B compared to A, which is just the difference in the mean cost of our strategy B minus the mean cost of our strategy A. So just looking at that incremental cost, how much more are we paying for this intervention? And it's divided by the incremental health benefits of the strategy. And that would be calculating the mean sort of health effects of our strategy B and subtracting the mean health effects of our strategy A. So overall, this would give us something like an incremental cost per health benefit gained, or per negative health averted. Now, how do we measure health? This is often used where we describe quality, where we use quality adjusted life years or disability adjusted life years, QALYs or DALYs. You may have heard about this in the literature. So just a little reminder, these are measures which combine both the duration of life with the quality of that life. So a quality adjusted life year measure is on a scale from usually 0 to 1, 0 being death and 1 being perfect health. Actually, QALYs can be negative. Some individuals report being in disease stages that they report are worse than death, but generally they are between 0 and 1. And so if we are simulating an individual that has 1 year of perfect health, that would be equivalent to 1 year of quality adjusted life year. So if a treatment gives us an additional 1 year of perfect health, it would give us an additional 1 QALY. However, sometimes treatments give us additional years of health, but not at perfect health, right? So if we have 1 year of health, but it's 50% of perfect, that would be a half a QALY. If a treatment gives us 2 years of health at 50% of perfect, that would be 2 times a half, or an additional 1 QALY. So the idea here really is that we're taking this metric and it allows us to combine both the additional duration of health benefits as well as the quality of those health benefits. And that is the measure that we use in the denominator to measure our incremental health benefits. Now, I've used the example of QALYs in this example where in the study that I'll be talking about, we use disability adjusted life years. That's sort of the opposite of QALYs. They're the sort of negative health. You don't need to get too wrapped up in it, but the idea is here is the outcome will be our incremental costs per our incremental health benefit. And here it's disability adjusted life years averted. So we have this ICER, this incremental cost per health benefit, and we can compare it across infections because we can calculate ICERs per their QALY or per their DALY across numerous infections. And we can compare it to what's called a willingness to pay threshold. Now, willingness to pay threshold is what is defined by a local government of what they're willing to pay for a health intervention. This is different for each different country, depending on what their health system is willing to pay. But based on the country level willingness to pay, if the ICER is below that willingness to pay, the intervention is likely cost effective. This always feels a little bit counterintuitive, but the idea is, remember, the ICER is the incremental cost per health benefit. So if our incremental cost is per health benefit is very, very low, it means we're spending not a lot to get our health benefit. If our incremental cost is very high, we're spending a lot to get that same health benefit. So we want our ICERs to be lower. That means that it's more likely to be cost effective. Okay, so for our ESCUDO evaluation, we then simulate an intervention and a comparator, right? This analysis is comparative. We want to know, is ESCUDO cost effective to not having ESCUDO? So here we're comparing a scenario with our ESCUDO effect on changes in incarceration patterns, which we obtained through our statistical analyses. And we want to compare it to a scenario with no ESCUDO, our stable incarceration patterns. And we need to know something about our costs. So Javier collected the costs of the ESCUDO intervention, which he obtained via microcosting methods to calculate all the costs of the intervention development, piloting, and delivery. And what he found was that the intervention costs $129 per officer trained, but would have cost significantly less if it was adapted further by local researchers. It was initially adapted by UCSD researchers, but if it was adapted by locally trained staff and local resources, then it could have been substantially less, and I'll get back to that in a moment. So we have the cost of the intervention, but we also need to know the costs of the other health outcomes in our model. So for example, the cost of ART, if an individual gets HIV and needs to be put on antiretroviral therapy. And we also simulate the cost of incarceration because the intervention had an impact on reducing incarceration, and therefore there are prevented costs related to incarcerating those individuals as well. So we estimated the cost of incarceration and we include those costs in the model. We evaluate cost effectiveness analysis just using a 2-year intervention effect. So we only assume that the intervention has the effect on reducing incarceration for 2 years. And then we assume that after 2 years, our incarceration rates go back to where they were prior to the intervention. So we feel that this is very conservative because we actually saw incarceration continue to decline after the 2-year period where the officers were under follow-up, but we just wanted to be conservative in that effect estimate. So we simulate this reduction in incarceration effect for 2 years, but then that goes back to normal, but we use what's called a 50-year time horizon. And that means that we simulate the changes in incarceration for 2 years. They go back to normal after 2 years, but we continue the simulation to look at long-term health outcomes over 50 years in order to capture the full benefits of the impact of that brief intervention on preventing onwards chains of transmissions of infections, right? People that didn't get infected during those 2 years would then not infect other people with HIV in the years afterwards. And our intervention also, of course, then has a long-term impact on health outcomes among the people that didn't get infected over that subsequent period. So we use a long time horizon to capture the full long-term benefits of this intervention. We track our costs in US dollars and our health utilities in disability adjusted life years, both among current people who inject drugs as well as ex-people who inject drugs. And we calculate this incremental cost effectiveness ratio, or ICER. As I mentioned before, we compare this ICER in incremental costs per DALY averted compared to a willingness to pay threshold of, this is a sort of a tricky thing. There's no set willingness to pay threshold in Mexico. Some of the guidance that has been given by the WHO was that using the per capita GDP of a country would indicate that an intervention was cost effective. So that's roughly $8,000 in 2020. Other economic teams have estimated that appropriate willingness to pay thresholds in Mexico range between, let's say, $4,000 and $12,000 in that similar time period. So we can kind of look at these different willingness to pay thresholds, either $8,000 or between $4,000 and $12,000. And so first, what did we find in the costs. So again, this is led by Javier Cepeda. It's work that is forthcoming in a Lancet Commission on Health and Human Rights. And what we saw here, first we looked just at total costs over the 2-year period. The left-hand side is the total cost without the intervention. The orange bar are our ART costs, and the blue bar is our cost of incarceration of people who inject drugs. So you can see about half the costs that are attributable to incarceration. And then on the right-hand side here are the projected costs over just this 2-year period with the ESCUDO intervention, the gray being the cost of the intervention itself. So you can see that while there was a substantial cost to the intervention, it was also associated with a substantial reduction in costs associated with incarceration. So the majority of the costs associated with the intervention were actually offset by reductions in incarceration costs. But we do see an increase in total costs of the intervention. And the question is, are the increase in costs worth the increase in benefits? And we found that they were. I showed you in the previous work, the previous slides, that the intervention was associated with reduced HIV infections as well as fatal overdose. And overall, when you feed that into a model looking at the overall cost effectiveness of the intervention, what we found is that the mean incremental cost effectiveness ratio was $3,700 per DALI averted, which is well below the willingness to pay threshold, either the per capita GDP at about 8,000 or this range of thresholds between, let's say, 4,000 and 12,000 that have been deemed appropriate by other economists. Okay, so the intervention was likely cost effective with our sort of base case assumptions, but we also wanted to run some sensitivity analyses. We look at here, what we're showing is how changes in different assumptions affects the incremental cost effectiveness ratio here, which is on the x-axis. So just a reminder that that if this number is bigger, it means that the intervention is less cost effective. And here, the vertical line here is what our base case ICER was, that $3,700 number. And these dashed lines give us the sort of range of acceptabilities of willingness to pay thresholds that I was describing. So if an intervention falls sort of within or below this range, the intervention would be deemed cost effective. So you can see here that if we use a sort of very high discounting rate for our costs and health utilities, that pushes our intervention to be not cost effective. This effectively means that if we discount future impact and we really only care about immediate impact in terms of immediate costs incurred and immediate health benefits, we get less, it's less cost effective. And that makes sense because much of the impact that we see is accrued long term. We're averting HIV deaths kind of 10 years in the future. We're averting long-term effects in terms of HIV prevention interventions. We have uncertainty in our intervention effect. So if we take a less conservative intervention effect, then our intervention is less cost effective, but still within this willingness to pay sort of area. And so it still probably remains cost effective. But the two things I wanted to focus on most are two things that make our intervention substantially more cost effective. The first is when we include the potential additional impact of this intervention on preventing hepatitis C virus infections. This is a totally separate piece of work that was led by Carlos Rivera Saldon as part of his PhD, where he developed a hepatitis C transmission model among people who inject drugs in Tijuana, incorporating incarceration. And he used that model to simulate the same intervention effect that I've just shown you in terms of the ESCUDO project reducing incarceration. And he found that with that 7% of hepatitis C infections could be averted over 10 years with the ESCUDO intervention. This is work that was just published in Addiction. And if we add those benefits into our cost effectiveness model, what we find is that the intervention is even more cost effective, substantially reducing our incremental cost effectiveness ratio. But also, if we have longer effects, right? If we have a 10-year effect instead of a 2-year effect, even if we include retraining costs, this intervention could be cost effective. And most critically on the right-hand side here, what we found is that if the intervention was developed and implemented with local investigators, so if it was replicated in other settings in Mexico that maybe have similar characteristics as ours, or if it was implemented and retrained using local investigators in Tijuana over time, the intervention could actually be cost saving. Saving money and preventing all the costs associated with incarceration, as well as preventing HIV infections and averting HIV ART related costs. So overall, this work, I think, provides a really interesting example where drug policy reform alone was insufficient to change the lived experience of people who inject drugs in Mexico, really highlighting what Leo Beletsky and his colleagues call this policy implementation gap. We have these laws on the books, but do they, and why don't they change the lived experience of people who inject drugs on the ground? As I mentioned, in part, this is because officers just did not know about these reforms and they weren't given the tools to actually enact these reforms on the ground. And so what this means I think the implications for other countries that are looking at policies that will decriminalize possession of drugs is that, those policy changes are very promising, but we may need structural interventions such as police education programs to help align both police attitudes about and take more a public health policy, public health approach, but also align policing practices with these reforms in order to ensure that it changes the lived experience on the ground among people who inject drugs. And at least what we've seen in Tijuana is that these structural police education programs can be both effective at preventing HIV, viral hepatitis, as well as overdose, but also potentially cost effective or even cost saving. Now, I will say that there's a number of limitations of this work. Of course, there's uncertainty in a number of our parameters. There was uncertainty in our intervention effect. But most importantly, we cannot really confirm causality, right? We saw and we used these regression analyses to try to look at how there was observed changes in incarceration patterns over time, pre and post ESCUDO. We triangulated this and saw that they aligned with changes in self-reported behaviors among the police prior to the training, but after the training. But of course, we still cannot directly confirm causality. And so we need further research to really disentangle and understand how these police education programs actually do result in changes in exposures among people who inject drugs on the ground, and assessment in other settings to confirm our results. With that, I'd like to thank the many collaborators that have worked on these studies and contributed data over a number of years at UCSD, particularly Stephanie Strathby and Borquez, the others that I mentioned in this study, as well as our co-investigators at Johns Hopkins, the co-investigators and study participants in Tijuana, as well as Ciudad Juarez, who have participated in this work over the years. And of course, the funders, this sort of leverages, as I mentioned, kind of 15 years of work that mainly has been funded by NIDA and the US border region, as well as NIAID and NIMH. So thank you again, and I would be very happy to take any questions.
Thank you so much, Natasha. I know you said I've listened to this talk a few times, but actually it just makes me realize how the narrative keeps developing and new methods are added. And I think it's a really interesting research narrative that's a testament of doing research in the same setting over many years and adding interventions and incorporating novel methods to understand what's happening. So thank you so much. It was so interesting, and I think it was also a good academic exposure for those who might not be as familiar with economic modeling or infectious disease modeling. I'll go straight to a question that Nettie had regarding the directionality of the effect of incarceration. So she was saying that folks with certain attributes are more likely to engage in activities that get them incarcerated. So that the link might go the other way around. So how do you determine if this is an effect of incarceration itself, or if it's?
That's a great question.
This was back to your initial premise way at the beginning, just saying, I could see, sorry, hi, it's Nettie. That was a great talk. Thank you. Really interesting. I was at the very beginning, you kind of said, well, we saw this effect of incarceration on substance use and injection drug use, which is completely plausible to me. But I also just wondered a little more about how you determined that was a direct effect.
Yeah, I think that's a great question. Okay, so one of the ways that we try to do this, bringing it back to the initial analyses done by Carlos Rivera, is that you're absolutely right that we often see that people who inject drugs who are incarcerated are sort of a higher risk subset anyway. His analysis was interesting. As I mentioned, one of the things that we did was we looked at people who were recruited into the cohort of people who inject drugs in Tijuana that had never been incarcerated at baseline. That's actually a very small proportion of individuals. The vast majority of them had been incarcerated prior to their entering the cohort, and sort of in my mind would have already been the sort of higher risk, individuals who had higher risk and may have been incarcerated. So we started in that analysis with a subset of individuals who had never been incarcerated, and then looked longitudinally over time at their exposures with their incarceration. And that was when we were able to say that not only did their first incarceration appear to increase the risk of syringe sharing directly after they reported being incarcerated, but that this risk increased over time as they had repeated incarcerations and persisted post-release. So again, I think there are questions about causality in terms of incarceration, but that at least helped us look within a subset of individuals that had really never been incarcerated before. And of course, we do know that there's good evidence that the immediate period post-incarceration is associated with a very high risk of fatal overdose, as well as acquisition of HIV and hepatitis C. It's a period of reentering the community where their networks are destabilized. There may be periods of unstable housing. Their tolerance to drugs has changed since they've been incarcerated. So, I think that there is this body of literature that supports that the process of incarceration can directly contribute to risks, but I agree with you, we do need more information to really understand that causality piece.
It would be interesting to look at people's experiences. I was just reading something last night in the paper about sort of the association with hopelessness and seeing fewer options in relation to worsening drug use. And so be interesting, maybe Stephanie's group has looked at how people feel when they leave incarceration, and if their sense of agency or control or hope for the future has declined, and then that also is a risk factor for worse drug use.
Absolutely. If there are other people on this call that can comment on that, I think that's a great point. And there are a number of researchers in the division that are very interested in looking at housing and unstable housing and how that affects it. And of course, sorry, one more thing that I didn't mention, but it is probably obvious, is that incarceration itself is we know disrupts access to harm reduction interventions as well as treatment. And so that process often, leads to that disruption and re-engagement in the community does not always release into the community, it does not always mean re-engagement in harm reduction. And so really those gaps in interventions which focus on supporting initiation of harm reduction in prison, as well as linkage once they re-enter the community, and addressing these more structural issues that you mentioned in terms of housing, really could help address that risk period.
Thank you, Natasha. I see Susan has a question as well.
Yeah, thank you. So my question, thank you, Natasha, that was great. My question is, how often when you, and you may not know this, but how often when you find an intervention is good value for money, do you see it implemented? And are there, implementation science? Are there studies that look at the likelihood of an intervention being accepted, and or, I'm sure you could model, the effect of additional interventions that you can show are good value for money, but they haven't implemented them. What's the next step?
Yeah, and that's a great question and a really difficult one. I will say that in my experience, the one example that I can point to is that we did a lot of work in hepatitis C, building models to show that treatment of people who were actively injecting drugs was cost effective. There had been many papers that have been published saying that treatment of people with a risk of reinfection, because hepatitis C treatment does not prevent reinfection. So initial concern had been, well, if we treat these individuals and they get reinfected, will that just make it the intervention not cost effective? And some initial economic modeling that did not include prevention benefits, but just included the risk of reinfection said, yeah, it's not as good as treating somebody who is no longer injecting and can't get reinfected and doesn't have this competing risk of overdose. We published a paper on that piece that incorporated the idea that when you treat somebody who is actively injecting and cure their hepatitis C, then they can't transmit to other people. Yes, they may get reinfected, but looking at that totality of benefits showed that treatment of people who inject drugs is actually likely to be more cost effective because you get those substantial prevention benefits. That work was directly cited in the WHO hepatitis C testing and treatment recommendations. And there's a sentence in the WHO recommendations that says, so the recommendation is that everyone should be everyone should be evaluated for hepatitis C treatment, including people who inject drugs. And that clause was explicitly put in there and referenced to say, we reviewed economic modeling evidence that show the treatment of people who inject drugs is cost effective and could be more cost effective. And really pushing governments not to turn their back and kind of exclude this population, which had commonly been done. So that was an example of where I think the economic modeling of, it's not a type of intervention was used to really advocate for policy change at a national level. To your point, more specifically, though, about kind of implementation science in Mexico, is this study going to lead to funding of police education programs? I don't know whether that's the case. I would hope so, but unfortunately, since the current president took over, he's been consistently cutting funding for harm reduction. As I mentioned, there's this methadone shortage, closure of a methadone plant. We don't see any scale up of syringe service programs. So I'm not optimistic that it will necessarily change things in Mexico. But having said that, what we're doing is we're using this data and there actually have been a number of studies led by Leo's team across the United States to look at the impact of these interventions. And it's providing us the preliminary data that we need to say, look, this could be cost effective. So let's evaluate this in the US and do more of an implementation science project in multiple US sites to see whether there's impact and cost effectiveness here that may have impact. But
yeah, that'd be great.
I think we need a lot more research in this area, honestly. We need to evaluate when is it that these economic, these evaluations actually inform and change policy. It's a great question.
I think that leads very nicely to another question that Nettie had about how do you explain these relatively complex analyses to policymakers who might not have the time or the interest to listen to an hour talk about methods and results. So how do you transmit that information?
Yeah. Two or three slides, and they're not too interested in the details about the model assumptions and the methods that we're using. They just want to know the big picture answer. There is a great group that's led by Bruce Shackman at Cornell called the Cherish Institute, and they work a lot on dissemination. And I've learned a lot from them over the years in terms of developing, for example, policy briefs. So just trying to disseminate the information in ways that, you know, yes, they're probably not going to read the academic publication. They may or may want to look at it, but being able to give them information in a digestible format, like a one-page policy brief that just really gives them the high-level results, or 2 PowerPoint slides that they can look at the main results, I think has been the best way of communication that I've experienced.
Natasha, there was also a question. I mean, it's not about the talk, but I don't want to miss it. It's asking about the one-year fellowship, whether it's open to medical graduates without US citizenship.
Great. I'll answer that. Can I actually just add one thing to
Yeah,
the
sure.
question about dissemination? The other thing that we've done that's been highly effective is partner with community-based organizations and help translate our findings to them and advocacy groups. And then they use the findings to advocate and communicate directly to the government. And so what's worked best with that is actually they do really like kind of seeing the whole, they're interested in the data, they want to see a bit of the presentation, but working with them on their reports and any of the briefs that they're working on to kind of integrate the modeling findings as well as the economics in easily digestible figures for that. And so that partnership has been incredibly valuable, and we've leveraged those as well. And I will say that on the other end of that, there's a lot of work that's being done incorporating both people with lived and living experience and communities organizations early on in the research to really drive the research questions to make sure that what we're doing with the modeling is actually relevant. Kind of back to Susan's point, right? So if we go and do all this fancy modeling and do all this economics, is it A, answering the question that we think it is relevant to the community, but B, is providing the right information in terms of outcomes or numbers that will have the most influence on changing policy. And so that's where, really having those strong community links early on in the process is valuable. And then the question about the fellowship. The fellowship is open to foreign medical graduates without US citizenship in the countries where we operate the GloCal program. So I'll put the link in the chat. There's about 17 countries. They have to be affiliated with that international site. And so if they're affiliated with that international site and they want to work on a program in that site, they can do that. And I'll put that link in the chat so you can review those sites. So yes.
But I think it's not open to those who are in the US already, but might not be citizens or have a green card, right?
It would be open to them if they wanted to do their fellowship in that international site. So the requirement is that you spend 11 out of 12 months in the international site, or it's like, actually for LMIC fellows, they have to spend a couple months in the US, but let's say, the majority of their year, they need to spend living and working at the international site. So if they're in the United States right now, they're foreign medical graduates, they don't have US citizenship, they could apply to be affiliated with one of those LMIC sites and located there. So if they have that affiliation.
Thank you, Natasha. Sorry, everybody, there's construction in my next door building. We have 2 minutes left, and I thought it'd be interesting if you could comment on the relevance of this work to what's currently happening in the US in terms of fentanyl felonization laws, where bills are coming up all around the country where having over 1 gram of drugs with fentanyl in them is now considered a felony. So kind of we seem to be going in the opposite direction in the context of the fentanyl crisis in the US. So I'd be interested to hear your thoughts on that.
Yeah, I mean, it's a great question. And I hope that you are planning on doing some of this work yourself, Monique, because I mean, I absolutely think that this could lead to negative health outcomes, and criminalization in general is associated with so many negative health outcomes, not just HIV, hepatitis C, and overdose. And so having laws like that are really a step backwards. And I do think some quantitative work just kind of showing the potential negative impact of that on these long-term downstream outcomes could could be helpful and would be a really worthwhile area of research.
Thank you. And I'm really sorry I missed one of the questions by Chris Matthews. What alternative interventions have been considered? For example, holding incarceration rates constant. What would be the cost effectiveness of offering MAT of inmates and upon release?
Yeah, so many good questions. Nick's been working on some of the work in terms of thinking about offering MAT in prison and on release, and many of other people have looked at that in other settings as well. And I'm happy to send over papers if you're interested in that topic.
Great, thank you so much, Natasha. This was a great discussion, and thanks everybody for an engaging discussion after the talk.
Really
Thanks all.
fantastic.
Happy
Thank you.
Friday.
Have a great weekend. Thanks all. Bye.